Welcome back to the deep dive. Our goal, as always, is to take stacks of clinical data, dense research papers, and crucial findings, and really distill them into knowledge you can absorb quickly and thoroughly.
And not just the data, but the context, right? The
Yeah,
so what behind the headlines.
exactly. So today we are deep diving into a seemingly simple, yet I think profoundly impactful clinical finding from the world of cardiothoracic surgery.
Mm.
We're investigating a respiratory support technique, high flow nasal oxygen, or HFNO, and how its application before a major heart operation might just be revolutionizing patient recovery.
And that before is the key word here. It's a proactive, not a reactive measure.
It is. Our mission today is to unpack a set of findings that were, well, they were highly scrutinized when they were presented at the prestigious CHEST 2021 annual meeting.
Which is a big deal. I mean, for anyone unfamiliar, the CHEST meeting is one of the premier global forums for chest and respiratory medicine. If research makes waves there, people listen.
Absolutely. So the core takeaway we are targeting is this. The research suggests that a non-invasive preparatory measure can drastically cut recovery time, reduce complication risk for the most vulnerable cardiac patients, and, ultimately save the healthcare system significant money.
A triple win, really.
It really is. Okay, let's unpack this. What was the central clinical problem that drove this research by Surang Patil and team, and what were the two specific aims they set out to achieve?
That's the perfect starting point. Because context here is absolutely everything. When a patient undergoes major cardiac surgery, the procedure itself, especially if it involves a sternotomy and cardiopulmonary bypass, it's just a massive physiological stressor.
Right, the whole body is under assault.
It is. The heart, of course, is the main focus, but the lungs almost universally suffer a temporary setback. And historically, postoperative pulmonary complications are, well, they're the single most common cause of morbidity and mortality following major surgery.
So not the heart, but the lungs are the weak link in recovery.
Often, yes. They significantly increase the burden on ICU resources. We're talking about things like atelectasis, pleural effusions, respiratory failure, and the big one they specifically targeted, ventilator-associated pneumonia, VAP. So with that in mind, the researchers set out with a dual purpose. The first was pretty straightforward, to formally study and quantify the role of preoperative HFNO oxygenation in these patients. They just wanted objective data on whether this preventative measure actually made a difference.
You had some hard numbers on it.
Exactly. But the second, and I'd argue the more clinically urgent goal, was to study the effects of this preoperative HFNO in the prevention of VAP.
And VAP is a massive issue, right?
Oh, it's huge. It's an acquired infection that carries incredibly high mortality rates, it prolongs ventilator dependence, and it costs an astronomical amount to treat. We're talking extended hospital stays, potent, expensive antibiotics. I mean, if you can prevent VAP, you've won a really significant battle.
So it sounds like they are identifying the Achilles heel of cardiac recovery, these pulmonary complications, and trying to reinforce it before the patient is even put under the strain of surgery. It's a shift from reactive treatment to proactive rehabilitation.
Precisely. And that framing is so critical. We know these cardiac patients are already compromised. They have heart disease, which often means reduced cardiac output impacting lung perfusion. So then you layer on pre-existing lung conditions, COPD, obesity, a history of smoking, and you have a patient population that is almost guaranteed to struggle post-operatively. The study wasn't looking at low-risk, healthy individuals. It was designed to test the power of this intervention on the patients we worry about the most.
Okay, let's talk about that specific patient pool, because for you, the learner, understanding the inclusion criteria is it's paramount to knowing where this data applies in the real world. They weren't just taking any elective cardiac surgery patient.
No, not at all. They were very specific. They targeted high-risk individuals.
So what were those basic sort of non-negotiable filters to even get into the study?
The foundational criteria ensured they were studying a specific surgical window and demographic. First, the procedure had to be elective cardiac surgery.
Okay, so no emergencies.
Right. And that's important because it rules out emergency procedures, like after a massive trauma or an acute heart attack, where there just isn't time for any form of measured preoperative preparation. This allowed them to isolate the effect of the planned HFNO.
Makes sense. What was the other one?
Second, patients had to be over 18 years old, which grounds the findings strictly in the adult population. It avoids all the physiological complexities and ethical constraints of pediatric medicine.
Okay, so those are the bookends. But the real meat of the selection criteria lay in the pulmonary risk profile. A patient only needed one of 7 specific risk factors to qualify. That is a very precise way to define high risk.
It is, and the study design really deserves credit for this precision. They recognize that pulmonary risk isn't monolithic. It can come from chronic disease, recent infection, mechanical strain, structural damage,
The whole spectrum.
the whole spectrum. And by requiring only one of these seven, they really captured the full range of common high-risk profiles you'd encounter on a cardiothoracic ward.
So let's walk through those seven. What was the first?
The first factor is probably the most obvious one,
Right.
a formal diagnosis of COPD or asthma. These are classic obstructive airway diseases.
Right.
Patients with COPD in particular have lost lung elasticity, and they often suffer from chronic air trapping. So when they're intubated and anesthetized, their lungs struggle significantly with re-expansion, leading to guaranteed atelectasis and difficulty clearing secretions after they're extubated. Their baseline pulmonary reserve is it's already extremely limited.
So any pre-existing structural and inflammatory damage puts them right at the top of the risk ladder.
Right.
What about more recent acute issues?
Yeah, that leads directly to the second factor, having had a lower respiratory tract infection in the preceding 4 weeks.
Ah,
Think about the clinical implication there. These patients are coming into major elective surgery while their lungs are still inflamed, possibly harboring residual mucus, and their local immune defenses are, depleted from fighting off a recent illness.
so you're introducing a huge surgical insult on top of a system that's already weakened.
Exactly. You introduce an endotracheal tube anesthesia on top of that recent infection. It dramatically increases the likelihood of that residual inflammation turning into a full-blown postoperative pneumonia.
I see. And the third criterion, you mentioned mechanical vulnerability.
Yes. A BMI of 35 or greater, this is class 2 or greater obesity. And obesity impacts the lungs in a major way, mostly due to mechanical restriction. The massive volume of abdominal contents just pushes upwards against the diaphragm, restricting its full downward movement, which is essential for deep breathing.
That sounds like trying to inflate a balloon that's already being squeezed from the bottom.
That's a perfect analogy.
Exactly.
It reduces the patient's functional residual capacity, which is the volume of air left in the lungs after a normal exhale. And when they lie flat for surgery, this compression gets worse, making them prone to alveolar collapse or atelectasis, even during pre-oxygenation.
And after surgery, they'd struggle to take deep breaths because of the pain, which just makes the problem worse.
Compounding the problem, yes.
Okay, so what was number 4?
The fourth factor addresses long-term lifestyle damage. Being a current heavy smoker, defined as greater than 10 pack years within the last 6 weeks.
And we all know smoking is bad for the lungs. But what's the specific mechanism that makes them so high risk for this kind of surgery?
Well, we need to be really clear about the damage here.
Yeah.
Smoking paralyzes the cilia, those tiny little hair-like structures that line the airways.
The ones that sweep everything out.
Right. They're responsible for sweeping mucus and debris out of the lungs. If the cilia paralyzed, mucus just stagnates. And stagnant mucus is a perfect breeding ground for bacteria, directly increasing the risk of VAP.
Right.
Plus, chronic smoke exposure causes microstructural damage that impairs oxygen transfer at the alveolar level.
So it's basically a total breakdown of the entire pulmonary defense mechanism. What about those chronic infectious diseases that leave permanent scarring?
That brings us to the final 3, which all deal with permanent structural changes. Number 5, a past history of pulmonary tuberculosis.
TB.
Yeah, TB lesions heal with significant scarring and fibrosis. This tissue is stiff, it's non-compliant. So even years after recovery, that scarring impairs lung mechanics, reducing gas exchange efficiency and making the patient susceptible to respiratory compromise under stress.
I see. And number 6.
Number 6, a known case of bronchiectasis. This condition involves irreversible, chronic dilation and destruction of the airways. They form these little sacs where secretions pool. These patients are already in a state of chronic, low-grade infection and struggle immensely with pulmonary hygiene. They are extremely challenging post-op cases.
And the last one, number 7.
And finally, number 7, a known case of fibrocavitary lung disease. This is a severe form of structural damage. You have stiff, scarred, and often hollowed-out areas within the lung tissue itself. Like the TB scarring, this severely compromises the effective functional lung volume available for gas exchange and elasticity. They have very little reserve to fall back on after surgery.
It's crystal clear now that the researchers were targeting patients who, based on their history or physiology, were facing an almost inevitable post-operative pulmonary struggle. But there was that one crucial functional requirement, the ability to perform a 6-minute walk test, 6 MWT. Why was that essential?
That requirement acts as a proxy for the patient's baseline functional reserve and their overall health status. The 6MWT is a measure of submaximal exercise capacity. If a patient is unable to walk for 6 minutes, it generally indicates a severe debilitating illness, whether it's cardiac, pulmonary, or neuromuscular.
So it's a way of making sure they had enough in the tank to actually recover.
Exactly. By requiring the 6MWT, the study ensured they weren't including patients who are already terminal or so functionally compromised that they couldn't even participate in the necessary post-op recovery efforts, like intensive physiotherapy.
I like your earlier analogy. You're studying patients who are driving a reliable car, but the tires are worn thin, not patients whose engines have already seized.
That's a great way to put it. It ensures the cohort had enough functional reserve for the intervention to actually make a measurable difference in the recovery trajectory.
That distinction is crucial. Now, let's quickly touch on the exclusion criteria, specifically two that really define the boundaries of the intervention success. Obviously, lack of consent is a given, and contraindications like a nasal septal defect. But they also excluded patients already on preoperative CPAP and patients who failed to meet extubation criteria by 10 a.m. on the first postoperative day.
And those two exclusions are really the key to interpreting the results.
Yeah.
Excluding preoperative CPAP users ensure they were measuring the impact of HFNO specifically, without any confounding variables from other existing respiratory support.
Right.
But the exclusion of patients who failed early extubation criteria, the ones who needed prolonged ventilation right out of the OR, that is a big clinical statement.
Let me play the devil's advocate here based on some common clinical skepticism. By excluding the most profound early failures, aren't they potentially skewing the results toward a positive outcome? How do we know that HFNO wasn't just ineffective for the highest risk of the high-risk group?
That's a very fair clinical question. And the answer, I think, lies in the study's primary goal: identifying an effective proactive strategy for the majority of high-risk patients. If a patient requires invasive ventilation for days immediately post-op, their failure is likely due to a multisystemic catastrophic event, severe heart failure, massive hemorrhage, overwhelming sepsis.
Things that HFNO was never going to prevent anyway.
Exactly. By excluding those who immediately fail extubation, the study focuses on the population where success is plausible but still very precarious. It allows them to accurately measure the impact of the preoperative intervention on tipping the balance away from pulmonary complications and toward a smooth recovery. It really defines the limits of the intervention's effectiveness.
That clarifies the focus. It's about optimizing the trajectory for patients who are at significant risk of a preventable pulmonary failure that would derail their entire recovery.
That's it in a nutshell.
So we know who they studied. Now let's move on to the intervention itself. HFNO is non-invasive, but its power is derived from very specific physical parameter. This isn't just, a nasal prong pushing a little extra oxygen.
Oh, not at all. It's a precisely controlled, high-flow system.
And we should probably clarify that terminology confusion in the source document, high-flow nasal oxygen therapy through face mask. Let's clarify for the listener, what is the fundamental difference between standard low-flow oxygen and this high-flow heated and humidified therapy?
That difference is where all the therapeutic benefit lives. Standard nasal prongs deliver room temperature, dry oxygen, and it flows usually less than 6 to 8 liters per minute.
Right, what most people picture.
Yeah. And that flow is inadequate to meet the patient's maximal inspiratory demand, which can be 30, 40, even 50 liters per minute, especially if they're anxious or breathing fast. This means the patient is still breathing in a lot of room air, which dilutes the effective oxygen fraction they actually receive. HFNO is totally different because it delivers flows that far exceed the patient's inspiratory demand up to 60 liters per minute, and it's heated and humidified to body temperature.
So there's a triple benefit there.
A triple benefit, yes. First, it delivers a precise and consistent FiO2, the fraction of inspired oxygen. Second, the high flow mechanically washes out CO2 from the upper airway dead space, which improves ventilation efficiency. And third, the heat and humidity are crucial for maintaining the function of the mucociliary escalator.
That self-cleaning mechanism we talked about with the smokers?
The very same one. It's often severely compromised in these high-risk patients.
So it's the physical conditions of the gas delivery, the high flow, the heat, the humidity, that turn it into a therapeutic tool far beyond just raising their oxygen saturation. Let's drill down into the detailed protocol they applied preoperatively.
Okay, the protocol is highly nuanced, which shows the care they took to balance optimization and patient safety. They started with FiO2 titration. The standard target was to achieve an oxygen saturation, or SpO2, of at least 95%.
So aiming for full saturation, basically.
Generally, yes, ensuring maximum oxygen carrying capacity before the surgical trauma. However, and this is a critical nuance, for the subgroup at risk of hypercapnoic respiratory failure. So, patients who struggle to clear carbon dioxide, most commonly those with severe, long-standing COPD for this group, the target SpO2 was deliberately lowered to at least 93%.
Now that detail is fascinating. It shows a real clinical respect for the established physiology of advanced COPD. We should probably elaborate on this concept of knocking out the respiratory drive for the listener.
Absolutely. In a healthy lung, the primary drive to breathe is dictated by rising levels of carbon dioxide. Your body senses the CO2, and you automatically breathe more often or deeper to clear it.
Okay.
In chronic CO2 retainers, so your severe COPD patients, this central CO2 sensing mechanism becomes blunted over time. It just doesn't work as well.
So they switch to a backup system.
They do. They switch to a secondary, more primitive mechanism. Their drive to breathe becomes dependent on sensing low oxygen levels. We call it the hypoxic drive. If you administer too much oxygen and push their SpO2 up to 100%, you completely remove that hypoxic stimulus.
And without a primary or a secondary drive?
Their respiratory rate slows dangerously, and they accumulate lethal amounts of CO2. So the protocol mandated that the FiO2 was actively titrated down to the minimum level required to maintain that 93% or higher target. It prevents this potentially disastrous loss of respiratory drive. This attention to detail really elevates the safety of the intervention.
That makes perfect sense. They're navigating a physiological tightrope for these specific patients. Now let's talk about the high flow part, the mechanics of the gas flow.
Right. The flow was started at 10 liters per minute, but this flow was not static. It was adjusted in a very tight range, specifically between 8 and 10 liters per minute, with the goal of achieving a physiological marker, a respiratory rate of less than 16 breaths per minute while ensuring the patient was comfortable.
So why use respiratory rate as the primary feedback metric for adjusting the flow rather than just oxygenation?
Because the goal of preoperative optimization isn't just oxygenation, it's respiratory muscle rest. High flow, by creating a small amount of positive pressure, what we call the PEEP effect, and washing out that dead space, it just makes breathing easier and more efficient.
So you're reducing their work of breathing.
Exactly. And when breathing becomes easier, the patient's intrinsic demand for rapid, shallow breaths, tachypnea, it just drops. By titrating the flow to get a respiratory rate below 16, they were proving the patient's work of breathing had decreased. The patient could then breathe slower and deeper, maximizing alveolar ventilation and ensuring they went into surgery in a state of respiratory rest and optimal lung recruitment instead of being fatigued.
So the flow adjustment was basically a physiological tuning dial, optimizing the patient's breathing pattern before the intense stress of the operation.
Precisely. They were aiming for maximal prehabilitation. Now, on the postoperative side, the duration was also very clear. HFNO2 was standardly discontinued after 24 hours, unless there was objective evidence of desaturation or tachypnoea.
So it was a bridge, not a long-term therapy.
It was a bridge, but they maintained clinical flexibility, allowing it to continue for more than 24 hours if the clinical need persisted. They prioritized patient stability over arbitrary time limits.
And crucially, both groups, the control group and the HFNO group, received the same standard postoperative respiratory care, physiotherapy, early mobilization, all that.
Yes, that confirms that the differences we're about to see are purely attributable to the HFNO intervention itself, above and beyond what is already excellent standard care.
And what if a patient started to deteriorate?
The protocol had a necessary contingency plan, a clear escalation pathway. If patients failed, the sequence was clear. First, you increase the FiO2, then you use CPAP or non-invasive ventilation, NIV, and only then do you resort to invasive ventilation, a very sensible layered approach.
We have the patient population defined, the precise intervention laid out. Now we get to the data. Here's where it gets really interesting. Focusing on the primary outcome, the headline was that the hospital length of stay was significantly less in the HFNO2 group.
And that reduction is really the ultimate proxy for clinical success. A shorter length of stay means fewer complications, faster functional recovery, reduced infection exposure, and, critically, lower healthcare resource utilization. It's the outcome everyone in the system wants to see.
So let's get into the numbers. How much of a difference are we talking about?
The numbers are, they're quite staggering for a preoperative intervention. The median hospital LOS for the overall high-risk cohort was approximately 7 days. But for the group that received the HFNO2 intervention, The mean hospital LOS was reduced by a remarkable 29%.
29%. A 29% reduction in mean stay after major cardiac surgery for a high-risk group. That translates to nearly 2 full days saved per patient. That's monumental.
It's monumental. In clinical terms, those 2 days are typically lost dealing with complications. A fever that needs investigation, difficulty weaning off oxygen, maybe a period of post-op delirium. Cutting 2 days suggests the patients just bypassed that common period of morbidity altogether.
They just got better faster.
They moved through the critical care phases faster and hit their mobilization goals earlier. And think about the capacity issue. A 29% reduction in average stay frees up hospital beds and nursing resources immediately. If a unit does 100 of these surgeries a year, that's almost 200 hospital days recovered annually, just from this simple, non-invasive pretreatment.
That's incredible. And what about prolonged stays? The really complicated cases.
They track that too. They defined a prolonged stay as greater than 10 days, which is often an indicator of a major complication. In the HFNO2 group, the incidence was only 18.7%. This low percentage strongly suggests the intervention was effective at steering patients away from those costly, high morbidity extended stays.
That addresses the primary outcome brilliantly. Now, what about the immediate post-operative period in the intensive care unit? What did the secondary outcomes show there?
The efficiency carried straight through to the highest level of care. The ICU length of stay was also significantly reduced, down to approximately 4 days. For high-risk cardiac patients, achieving an early step down from the ICU is vital. It's the most expensive resource, and patients are at the highest risk of hospital-acquired infection there.
And were these early discharges safe? Did patients bounce back to the ICU?
That's the key question, isn't it? The follow-up data was excellent. The ICU readmission rate was extremely low, reported at just 2%.
Wow.
That's a powerful metric. It tells us that the early extubation and step-down decisions were safe and sustainable. It validates the superior baseline pulmonary status they achieved with the HFNO pretreatment.
And what about the most critical outcome, mortality?
The results were very favorable for this high-risk population. In-hospital mortality was just 1 death. Now, we don't have the total cohort size here, but that low number strongly suggests that this strategy of preoperative pulmonary optimization significantly improved patient survival in this vulnerable group.
It's compelling evidence. It feels like by investing a few hours pre-op, you are literally buying days of faster, cleaner recovery post-op. But the study also provided a necessary point of clinical precision. They noted that extra pulmonary complications showed no difference between the groups.
And that's essential context. It confirms this isn't some magic bullet. It's a targeted pulmonary intervention. Issues like renal failure, deep vein thrombosis, or surgical site infections, complications unrelated to lung mechanics, they were unaffected. This really confirms the mechanism of action is focused squarely on the respiratory system.
Okay, let's pivot to the quality of that recovery. They looked at functional performance metrics, pulmonary function tests, and the 6-minute walk test on day 5 or 6 post-op. This tells us about the patient's return to life, not just their survival.
Absolutely. Survival is the baseline, but functional recovery is the real measure of success. Postoperative recovery involves pain, fatigue, muscle weakness, all of which compromise lung function.
So what did they find?
When we look at the specific functional results, the change is impressive. For the postoperative PFTs, the peak expiratory flow rate, or PEFR, which is a measure of forced expiration and cough strength, it improved to approximately 400 liters per minute.
400 liters per minute. That signifies a really robust recovery of the mechanics you need to clear your airways. If you can't cough effectively, you retain secretions, and that's a fast track to pneumonia.
Precisely. This PEFR recovery suggests the HFNO group maintained or very rapidly regained the mechanical ability to keep their lungs clean.
And what about the mobility metric, the 6-minute walk test?
This is incredible. Remember, this test was done on day 5 or 6, a time when many post-cardiac surgery patients are still struggling severely with fatigue and pain. The source reported that the distance traveled post-operatively was improved by approximately 200 meters.
That is an astonishing gain. To put that in perspective for you, that's 2 football fields. On day 5, after having your sternum cracked open, improving your functional walking distance by 200 meters, it speaks volumes about their physical and mental resilience.
It implies minimal fatigue, superior cardiovascular conditioning, and critically better pulmonary function, allowing them to oxygenate effectively during exertion. It just summarizes the profound difference this pre-op intervention made to their entire quality of recovery.
And what was the overall finding?
The overall finding was clear. The postoperative quality of recovery improved significantly, And this was evidenced by those functional metrics, the early discharge from ICU, and the significant reduced requirement of antibiotics.
And the reduction in antibiotic use is probably the most direct evidence that their primary goal, preventing VAP and other pulmonary infections, was successfully met.
It's the smoking gun, really.
Now we move from the numbers to the clinical synthesis, the so what, and the underlying mechanism. The study concluded that preoperative HFNO successfully reduced post-op pulmonary complications and infections, especially VAP. But how exactly does non-invasive support before surgery fundamentally change the patient's biological response after the operation?
The mechanism is a really powerful combination of proactive physiological optimization and damage mitigation. It just leverages the unique characteristics of high-flow, heated, humidified gas to prepare the lungs for trauma.
Okay, so what's the most important part of that?
The first, and I think the most important mechanism, is that HFNO2 reduces atelectasis. Atelectasis, the collapse of small areas of lung tissue, is basically inevitable after general anesthesia, especially in obese or COPD patients. HFNO combats this through its inherent positive end expiratory pressure effect, the PEEP effect.
Can you elaborate on that PEEP effect? How does a simple nasal cannula generate positive pressure?
It's all about flow physics. When you deliver gas at extremely high speeds, up to 60 liters per minute, into a constricted space like the nasal cavity, that flow physically impedes the patient's exhalation, especially if they exhale with their mouth closed. This restriction generates a small, continuous positive pressure, usually around 3 to 7 centimeters of H2O.
So it's not a huge amount of pressure, but it's enough to make a difference.
It's enough. This constant low-level positive pressure is sufficient to stent open the small airways and alveoli that would otherwise collapse under anesthesia. By keeping the lungs fully recruited and aerated before the patient even goes on a ventilator, you significantly reduce the lung injury and stiffening that occurs when those collapsed alveoli are violently re-expanded post-op. It's preventative lung recruitment.
That makes a lot of sense. What's the second mechanism?
Secondly, we revisit the role of humidification. By ensuring the gas is heated and humidified to near-body temperature, the HFNO actively supports the mucociliary escalator.
Right, our cleaning system.
Anesthesia and dry medical gases severely impair ciliary function. If you can maintain the cilia's ability to sweep, you ensure that the patient can effectively clear the accumulated secretions and debris that are inevitably introduced during intubation and surgery. This directly reduces the environment where VAP-causing bacteria love to thrive.
And the third mechanism?
Third, and perhaps most importantly in the context of VAP prevention, HFNO works to prevent respiratory failure and thus eliminate the need for prolonged intubation.
That's the critical link. Prolonged intubation is the golden ticket for VAP.
It's the front door. Exactly. The endotracheal tube is a physical conduit for bacteria straight into the sterile lower airways, bypassing all the natural filters of the nose and throat. If the patient is pre-optimized with open alveoli, less inflammation, rested respiratory muscles, they are far more likely to meet those extubation criteria by 10 a.m. on post-op day 1.
So the chain of events is HFNO keeps the lungs open, which means they come off the ventilator faster, which means the tube is in for less time, which means less chance for VAP.
You've got it. The HFNO intervention breaks the complication cycle at its earliest possible point.
So what does this all mean for the wider healthcare system and financial feasibility? The study concluded that the intervention helps to reduce the overall cost of treatment. Can we quantify the magnitude of that economic benefit?
The financial benefits are profound, especially in a system that's constrained by capacity and cost. We already saw the 29% reduction in overall length of stay and the reduced ICU stay. I mean, those savings alone, 2 days of acute care per patient, are substantial.
But the real gain is from VAP prevention, isn't it?
The real financial gain is VAP prevention, yes. VAP is incredibly expensive. A single case can add tens of thousands of dollars to a patient's bill. That's driven by the need for extended mechanical ventilation, prolonged ICU stay, endless lab tests, and multiple rounds of broad-spectrum, sometimes very specialized antibiotics.
So you're spending a little to save a lot.
A huge amount. By implementing a relatively low-cost, non-invasive prophylactic measure, a few hours of HFNO use pre-op, you are investing a few $100s to avoid a complication that costs potentially $20, $30, even $40,000 to treat. The economic return on investment here is immense. It makes this not just a superior clinical practice, but an incredibly efficient one.
Connecting the dots for the listener, we are looking at a simple, non-invasive preparation that transforms patient vulnerability into resilience. And that leads directly to measurable functional recovery that is faster, a lower risk of deadly infection, and it's financially beneficial for everyone involved. It's a classic case of ounce of prevention being worth a pound of cure.
And it really represents a paradigm shift in how we view prehabilitation.
Hmm.
We often focus on managing blood sugar or optimizing cardiac medications. This study proved that targeted, aggressive respiratory optimization right before surgery provides superior clinical returns, ensuring that the high-risk patient had the best possible chance to not just survive, but to thrive in their recovery.
A fantastic summary.
So to synthesize the key takeaways from this deep dive, the research on preoperative high-flow nasal oxygen in high-risk cardiac surgery patients delivered really unequivocal results. By applying this simple, non-invasive support before the operation, the patients experienced a measurably superior recovery trajectory. This included that mean hospital length of stay reduction of 29%, a shorter ICU stay of approximately 4 days, and superior physical recovery, which was highlighted by functional improvements like that 200-meter increase in their 6-minute walk test distance on day 5 post-op. It is a powerful validation of proactive pulmonary protection.
That is truly game-changing data, especially given the high mortality and cost associated with post-operative pulmonary complications. And this leads us to our final provocative thought for you to consider. This study focused specifically on cardiothoracic surgery because of the high pulmonary risk associated with that procedure. But the mechanisms HFNO uses, the PEEP effect, the dead space washout, supporting the mucociliary escalator, those are beneficial to any compromised lung.
Right. It's not specific to the heart.
Not at all. So think about all the other high-risk surgical fields. Long, open abdominal surgeries, major trauma cases, or geriatric patients undergoing complex orthopedic procedures. These patients are equally susceptible to atelectasis and VAP. So the question is, how many other surgical disciplines could benefit from immediately incorporating such a simple, non-invasive, preemptive respiratory strategy? How can we start effectively turning a common piece of hospital equipment into a powerful prophylactic tool across the entire surgical spectrum? What wider systemic applications might this study unlock if we stop thinking of HFNO only as a rescue device and start viewing it as essential preparatory medicine?
A great question to end on.
Thank you for joining us for the deep dive. We hope this has equipped you with the key insights from this crucial research. Until next time, keep learning.